Welcome to Cyber Survivor. I'm your host, Dan Dotson, and today I'm joined by our first physician as part of our Cyber Survivor series, which I'm very excited about. Dr. Jeff Tully is a board certified practicing physician, as well as a published researcher, thought leader, frequent speaker on numerous cybersecurity topics. He is currently the co-director of the UCSD Center for Healthcare Cybersecurity, as well as the associate clinical professor at the University of California, San Diego. Jeff, welcome to the podcast.
It's great to be with you, Dan. Thanks for having me.
Really excited to listen and learn from you today and hear your experiences. As we begin to dive in, if you would just share what got you interested in medicine and ultimately cybersecurity to begin with.
Great question, and I will try to keep this from being too long a story, but I was actually a patient in a hospital as I was growing up for a congenital condition, and so I had a lot of exposure to the healthcare space and really found that medicine resonated with the experiences that I had growing up. So I was always interested in going into some type of clinical profession. It ended up being medical school. And then when I was in medical school, I was able to combine another one of my interests, which was basically sort of informally tinkering around with computers, with one of my colleagues, Dr. Christian Demeff, who was my best friend from the very first day of med school and now is my research partner and co-director at the Center for Healthcare Cybersecurity. So Christian kind of introduced me into this world before it was known as cybersecurity of hackers and people who were interested in how computer systems worked in ways in which they could be manipulated or modified to kind of better understand their function. And so from a very early period in medical school, we were going to DEF CON. We were meeting some of the original medical device hackers. And that sort of transitioned into this more formal academic role once we started getting into the clinical environments in our training and realized that many of the same technologies and platforms that we had known to be vulnerable in other areas were systems that we were using to take care of patients. So for about the last 15 years or so, we've been very interested in understanding these intersections between medicine and technology, specifically in this field of healthcare cybersecurity, where these dependencies that we use to take care of patients can be exploited or disrupted, and the impact that that has on the subsequent outcomes in the clinic and the hospital.
That's fascinating. It's amazing how you've combined two passions together to make a big difference. And certainly healthcare is under attack and continues to be one of the most attacked industries. But I want to take a step back and just think about, we've digitized the way that we deliver care. And we're solely reliant on technology to coordinate care, deliver care within these communities, which has got a lot of benefits. We also hear physicians talk about the technology interrupting care from a workflow perspective. They spend more time on their keyboards. They're, at home charting at night. They've got now patient portals, et cetera. Do you think just broadly that the digitization of healthcare has increased the quality of care? And is it worth the offset of the increased attack surface?
I do. And I think that's a great question to start with. And I do want to make very clear, we are not Luddites. We do feel that the tools that we use every day, from the electronic health records to the systems that we use to harness laboratory radiology results, to a million others, even something as simple as the Outlook email by which I communicate with my colleagues or get my clinical schedule, that does, I think, enable us to take care of patients in a way that benefits from some of the foundational attributes of these platforms: clinical decision support, interoperability, to be able to have somebody come in on vacation, unfortunately breaking their ankle. I'm helping do the anesthesia for their surgery, and I can pull up their records from their main hospital in Vermont, right? Like that type of connectivity is very, very useful. And I think that we are in the early stages of another digital revolution with respect to things like consumer wearable technology, remote patient monitoring. And of course, you can't have a conversation these days or be in clinical medicine without having to bring AI into it at some point too. So I do think that there are lots of there's a lot of promise of these types of technology, but I think you're very right in understanding that there are also downsides. There is an associated peril, and that is this increasing attack surface. That is these dependencies that, when the technology is disrupted, result in challenges to the workflows that we have to maintain. So that's the trade-off. And I think we've over time come to appreciate that trade-off. And now I hope we can start to focus on ways in which we can make these systems more resilient, which I would be happy to get into at length, kind of what I think about when I say, how do we make our digital systems that we depend on more resilient? And how do we as physicians and clinicians, doctors, nurses taking care of patients, operate with more resilience in the setting of these incidents we'll talk about, like ransomware attacks or other technology failures?
Yeah, absolutely want to get into the resiliency conversation. Before we do, how have you seen the sentiment of your colleagues that may not have the same passion for cybersecurity that you do? How have you kind of seen that broadly change as they've begun to understand both the benefits and some of the challenges that's presented? Would you say that they're interested in continuing to invest in technology? Is it a frustrating point for them? How do they think about that?
Yeah, that's a great question, Dan. I would say in my role, I kind of wear two different hats. I'm sometimes a translator, a bridge between the more technical side of the house and my clinical colleagues. I don't have a fully operational role, but I'm certainly involved in conversations where these types of topics come up. And in speaking with my colleagues, 5 or 10 years ago, I would have to kind of raise a lot of awareness with respect to things like ransomware incidents or medical device cybersecurity vulnerabilities, and that was much more of sort of a light bulb moment for them to realize the implications of these types of issues. Now, in an era where we hear about a ransomware attack on a hospital, every couple of weeks in the news, where there's a big technology failure that results in widespread disruption to millions of computers across the world, like, my colleagues are dialed in now to understand that we do have these dependencies, and they are very interested in working on ways, I think, to increase clinical resiliency. They're a little bit less interested in, sort of mandatory trainings or the things that kind of eat away at their patient care time or force them to sort of focus more on the computer than the patient. But I think they understand, largely speaking, that we are not moving backwards. Like, we're only going to continue to become more digitally connected and dependent. And I do think that they are integrating that perspective into how they think about risks and benefits with other aspects of medicine, right? We think about the pros and cons of starting a particular medication or the risks of a specific surgery. I think they've been able to adapt that kind of mentality on that risk calculus with the increasing connectivity in healthcare.
Yeah, I definitely agree with you. That's kind of what we're hearing, is that, it's largely accepted that we're going to continue to move forward, right? And frankly, probably at a faster pace when we start thinking about,
Right.
embedding AI into various elements of the kind of care continuum, if you will.
Yep.
And I had an interesting conversation with a chief nursing officer that survived a ransomware situation. And, a lot of the younger clinicians and nurses, et cetera, they were not used to, delivering care without technology.
Yep.
They've known it since they went through their training. And so, availability and our ability to deliver care in these communities is paramount as we look to survive, these types of unfortunate events.
Yeah, so I think Christian and myself and the cohort of students coming up through med school back in the early 20 teens, we were some of the first folks to never practice writing a paper prescription pad or hanging up an X-ray on a light box, right? Or rounding and writing paper charts. And now I go back and think about that and be like, man, if I had to do my daily progress notes on 30 patients, writing it down on a piece of paper, that paper gets filed into a record. It may or may not get scanned, but it's going to kind of float around in the hospital with that patient, hopefully for other people to look at it. Like, to me, that is a very challenging way to operate. And so when we think about downtime and prolonged downtime and falling back on a lot of these practices, I don't have the personal comfort to be able to operate in that type of condition. And I think many of the modern, the current generation of docs and the ones coming behind us are in a similar boat. And so that's where I think it's really important to start thinking about this in a way that maybe older generations of physicians wouldn't have had as much of an issue with.
Yeah, I think that's absolutely right. So let's dive in. So what are some of the research topics that you've been exploring? What's top of mind for you as you think about building resiliency in clinical settings?
Yeah, so definitely, hold me back here if I get a little bit too nerdy or in the weeds. But here at the Center for Healthcare Cybersecurity, I think we're really interested in understanding the impact to patient outcomes that can come with technology failures. And technology failures is a pretty broad term, right? That can encompass ransomware attack, that could encompass a faulty software update that bricks, a million computers around the globe. And so understanding the way in which these dependencies, if adversely affected, then impact the care of patients, particularly patients with what we call kind of time-sensitive medical conditions. So things like stroke, heart attack, sepsis, trauma, right? Where the care really matters from the standpoint of how timely and efficacious it is, right? Certain conditions you can wait for your doctor to get back to you if you have a common cold or need a basic prescription filled. But if you have a heart attack or a stroke, the clock is ticking, and your ability to get timely care and the highest level of care is going to be directly impacting your ultimate outcomes. So a lot of our work is saying, hey, we know that we've seen media reports, we've seen a bunch of news stories, we've heard anecdotal posts on social media from patients saying that when they were in a hospital and there was a ransomware attack, it was very chaotic, very disruptive, right? Is there a way that we can start to measure or gather data about these topics in a way that really helps us understand the full impact, but then can give us some clues as to which interventions are most impactful from the standpoint of clinical resiliency and doctors and nurses taking care of patients, right? So I think it's important to kind of emphasize the perspective that we take is one of clinicians first and foremost, and view these technology incidents from the context of patient care and not necessarily as just something that's an IT problem. And so a lot of the work and the research that we do is focused on that. So just to kind of give you an example, there's not a lot of data out in the medical literature about patient outcomes associated with something like a ransomware attack. And so in 2023, we published some of that early data. And it's challenging to obtain that data, right? Number one, hospitals don't take it too kindly when random researchers show up and say, hey, you guys have just suffered an embarrassing, potentially devastating incident. Can you give us a bunch of sensitive data about what happened with that? But number two, a lot of the ways that we measure things like patient safety impacts, care quality, we leverage data that comes from connected systems like the electronic health record. And in a setting of a ransomware attack, that all goes away, right? And so even if you wanted to, even if you had a hospital that was willing to share a lot, there's sometimes it can be very challenging to actually get data that you can then use to make a hypothesis or examine a conclusion. So what we did in 2023 was kind of a unique and novel paper that looked at what happened to a hospital that was not affected by ransomware, but was in the adjacent vicinity of a system that was. So in other words, in a local regional area, there are a couple of different hospital systems. One of them was hit by Conti ransomware back in 2021. And we were able to obtain data from a system that was very close geographically that ultimately got a lot of the patients from that affected system, right? And so we looked primarily at data from the emergency room. We saw that compared to sort of the normal pre-ransomware period in this ecosystem, there were many more patients coming to the unaffected hospital to seek care. Patients waited longer in the emergency department. Many of the patients left without being seen at a rate that was higher than normal times. And then we also looked at sort of the overall emergency medical services picture in that geographic area. So when a hospital can't accept ambulances or helicopters transferring patients for whatever reason, that's called being on diversion. And the county system measures the total number of hours that all the hospitals tell them, hey, I can't take your patients, and kind of tally that up. And we got that data. And we saw that during this period where one system in this ecosystem was affected by ransomware, the number of overall EMS diversion hours skyrocketed to a period higher than that even seen during COVID. So it was this paper, it was published in JAMA Network Open in 2023, that really helped us build this mental model of cybersecurity incidents like ransomware and other technology failures. They are sort of public health issues. They cause a regional impact. You don't have to be a hospital hit by ransomware to suffer from these types of incidents if it occurs in your larger geographic or sort of networked area. So that led us to kind of start thinking about cybersecurity incidents, other technology failures, really as kind of almost like natural disasters like earthquakes or hurricanes, and that they have this potential to cause widespread disruption. And when we think about resiliency, we really think about it in the context of like, how can we ensure that our weakest link is as protected as possible, right? Because one failure can cause sort of these cascading ripple effects. So that was kind of one of our first big papers. We have since embarked on a number of projects I can talk about that sort of are trying to apply those lessons to more proactive sort of public health types of monitoring or epidemiology. We're taking a look at ways in which we can sort of surveil the digital infrastructure of our nation's healthcare ecosystem. We're looking at ways that we can help doctors and nurses that are on the ground during a ransomware attack respond with various clinical and technical tools. And then we're also doing some kind of interesting work too that is trying to bring data-driven research to some of the sort of orthodoxies that exist in cybersecurity, not just in healthcare, but in cybersecurity writ large. We published a paper last year that was a little bit controversial that looked at the efficacy of phishing training, right? Some of these practices that we do that we accept are sort of basic things that you have to do. How effective are they really? If we have folks spend time on minimum cybersecurity trainings or phishing trainings, do we actually see benefits? And are there ways in which we can adopt evidence-based research techniques from medicine to examine some of these problems in a little bit more of a controlled fashion? So that's a ton of stuff there. I'd be happy to kind of break down any of that, but I hope that gives a little bit of a flavor of the type of work that we do here at the center.
Yeah, that's fantastic work that you're doing. And, we often talk about, and hear about the impacts to the specific system that is going through the event. But for folks that are in the space, understand that, depending on the geographical region, it can overburden another health system that's unaffected, to your point. Question for you, as you're going through your research, we often think about this from the technical side of like, oh, I don't want to share what happened during my event because, there may be lawsuits and, third, fourth kind of levels of impact. But it sounds like you had some of those same challenges of just getting organizations that had been through that event to open up and share. Why do you think that is?
There's a number of factors, I think, and I just want to kind of preface this by saying that I will never personally speak about a single affected institution or sort of play any type of blame game. Like I understand these attacks are devastating. The folks that are on the ground trying to mitigate and manage them have a Herculean task, and I feel for these types of situations. And so there, but for the grace of God, go we, right? I never want to cast any aspersions on whether or not a institution might be open to sharing these types of data, because I get it. There's a number of considerations. So number one, big reputational concerns, right? Regulatory impacts, large scale class action liability, right? There's a number of ways in which I think that folks who may not be directly involved in this type of research may have concerns from sort of a risk mitigation standpoint. So I fully understand that. The institutions that I will talk about and call out by name are places like the University of Vermont, which have been fantastic about sharing their experiences with the wider community, publishing research, publishing guides as to what they did, what the workarounds they found. There's a great 3-part series from their pathology department saying basically this is the anatomy of a ransomware attack as it affected our department. These are all the workarounds and mitigations we found for the clinical issues. So there are institutions that are very forthcoming, and I think that is a very laudable position to take. And it is my hope that by continuing to do this type of research and being very responsible, de-identifying where we can, not sort of drawing any conclusions about, the underlying aspects of what happened, just presenting the data, I hope that we can engender a community that is a little bit more forthcoming with respect to some of this information, because it only helps everybody else, right? To be able to understand the ways in which your institution was impacted, the patients most at risk. That's how we start to develop the plans for resiliency, identify the patients that we can help, and kind of just raise overall preparedness.
Yeah, I completely agree with you. The adversaries are certainly coordinating their efforts through a very complex network, which I'm certain that you fully understand as well. And, I'd love to see the increase of the good guys sharing ideas and data. Certainly understand that organizations that go through this, they're victims, they've survived it. There's a lot of second and third level, impacts that got to be considered. But I'm hopeful that we can continue to share more information on how we can become more resilient as a network, as a combined ecosystem. One example you gave is, serving patients from another city. We move around the U.S. We've got to stay coordinated.
Yep.
I'm fascinated to understand your thoughts. I know you said it might be a bit controversial on the phishing, which is basically a simulation to help end users better be prepared for understanding when an adversary may be trying to, trick them into giving them credentials. For those of you that are non-technical, there's these programs that are in place to basically train end users to better identify. And part of the reason why they do that primarily is driven by it's still one of the top attack vectors.
Yep.
People try to target the human because they can get access into the environment. What were some of your findings, and what are some of your thoughts on your research?
Happy to explore that, Dan. If it's okay, I just want to add one clarifying point to the last topic, which is to say, I don't want there to be a misconception that there's no information sharing going on whatsoever, right? I mean, there are great organizations out there like the Health ISAC, the Health Sector Coordinating Council, folks at CISA. There is this network that is being built of collaboration and threat intelligence and things like that. That is very exciting and great to see. So, all right, phishing training. So this work is, I think, an example of kind of one of these established orthodoxies, right? Like, we think phishing training is helpful because we know this is the common vector. If we can train folks to be more aware of the potential threat, then clearly they will perform better, right? Like, that's kind of a very reasonable assumption to make, and it's one that is built on longstanding sort of best practices, expert opinion, all of these things which are very helpful in the beginning of a field, but then once you start to establish more formal research methods, those of us who are in kind of more rigorous science and know things like the hierarchy of evidence, right? Things like expert opinion and best practices are at the bottom of the pyramid, and there's, as you go up, greater degrees of more standardized and rigorous ways to set up a research question. So that's kind of what we attempted to do in medicine. Very commonly, if you have a new drug or a procedure and you want to kind of see what is the effect of this one intervention, you do something called a randomized controlled trial, which is you have different subgroups. Some of them get exposed to the effect, some of them don't. And then you kind of look at outcomes while trying to control as many confounding variables as possible. So we set up an experiment. And I think this is just kind of a credit to UC San Diego and the collaborations that we have with different folks across the health system, because we worked very, very carefully with our information security team, our IT teams, to set this up in such a way that we could try to have it as standardized and rigorous and controlled and blinded as possible. So we actually, we use a specific vendor for this phishing training. We kind of modified our methods a little bit. The regular training that folks were getting, we also introduced some additional new types of training. But the important part is we took different control groups. So we phished, we did test phishings across tens of thousands of employees at our health system over a period of about 8 months, and had different groups that were receiving different prompts, different phishing lures, and then if they failed that test, would receive different types of training, right? So there is like customized training where you can click a video, it's very specific to the lure you got. There's also just general, more static training where you click it and said, hey, this was a fish. Don't click these types of messages anymore. Be happy to drop this paper and any of the other things that I mentioned too after this, so that you can include them in show notes if you have those. But long story short, like, try to get very, very granular. So, hey, a certain number of folks got a certain type of phishing lure, and then they got exposed to either static or contextual training, and then what happened afterwards, right? And so, long story short, we didn't really see a big impact on the type of phishing training or the frequency in which it was applied, such that the people exposed to that intervention were substantially unlikely to fall for it again. The other thing that we looked at too was, there's phishing training. There's also kind of just like general cybersecurity training, right? We have a module that we go through. It takes half an hour. It introduces a bunch of different concepts: social engineering, phishing, all of these other vectors. And we were wondering, if you have that general cybersecurity training, and then you were to have a test phishing in close proximity to that, are you more likely to be protected versus somebody who last did their mandatory general training a year ago? And the answer to that from the data seems to be not really as well. And so lots of advanced statistics, different types of techniques that we tried to control for all these variables. But the overall result of the study was like, it didn't appear that there was a very substantial benefit to phishing training. And any benefit that was recognized with these different approaches could very easily be modified with how tricky you made the lure, right? So we did 10 different lures, from something as simple as like, hey, this random person's asking you for your password. Pretty obvious, right? To, hey, heads up, everybody, there's a new change in the dress code, or there's a new change in the vacation policy. You should click this and learn about this because it's going to be very important. Those types of lures can be very effective. So there are ways to sort of engineer lures that are much more challenging to recognize, and that outweighs any benefit from some of these more advanced phishing training techniques. So that's the study. Little controversial. Important to note, that's one example of data, right? And that's a hypothesis that was developed after gathering that data and analyzing that data. We encourage other people to do similar studies. We encourage people to challenge our methods. We encourage people to challenge our data, because that's kind of how science works, right? So we're not saying this is the end all be all, phishing training doesn't work, don't spend money on it. But what we are trying to do is introduce evidence that can help people make informed decisions when it comes time to allocate very limited resources. And over time, if we can do more of these studies, other centers can do studies like this, we start to build up this body of data and body of evidence that can be useful in making some of these decisions, and move beyond that orthodoxy of like, oh, we're doing it because we've always done it, and because the people on social media say this is the best thing to do, or because vendors have nice fancy pitch decks. Like, trying to bring a little bit more rigor into how we think about these practices.
During your research, did you find anything that you thought would be a recommendation to increase the effectiveness of phishing, or was there any
That's a good
material
question.
findings?
That's a great question, and I think that speaks to the need for additional studies where we look at other aspects of this. We look at different contents. Like, again, we don't want to say this one particular study suggests that there's no effective phishing or educational campaign whatsoever. What I do think we should consider is, like, maybe there are ways to think about the problem, and I think this is something that you alluded to earlier, Dan. Is can we think about a system in which we're not dependent on human beings being perfect 100% of the time and not having any room for failure, right? Are there checks, are there controls, are there mitigations, are there supports in which the human can be a part of the system, but not the single point of failure? Because we know that human beings are fallible, and there's no program out there that will reduce something like an employee falling for a phishing lure 100% of the time, right? So what are ways in which we can leverage new technologies? What are ways in which we can design our systems such that that single point of failure is not catastrophic?
Yeah. No, I think that makes a lot of sense. And the other thing that we're starting to see is, a lot of use of email, society, even if you zoom outside of healthcare, a lot of individuals kind of associate their employment with their email. Like, no one says that, but they do. Like, I'm a part of this. I have an email. I feel like that. And so what we're seeing a lot of health systems explore is like, who really needs external email to actually, perform the functions that they're there to perform, right? And so from a culture perspective, are there elements that we can put in place in lieu of training, or in addition to training, I might say, to decrease the attack surface, right? To help overcome this challenge. Because you're right. I mean, the adversaries, they used to, send an email that, a prince or princess wants to give you $1 million. Like, we're well past that now,
Right.
Jeff, as you know. I mean, these are
Right.
very sophisticated attacks. And so that type of training, no one's really falling for that at scale like they used to. And so how do we put other defense mechanisms, other trainings, reduce the attack surface to augment, some of the stuff that we're currently doing?
100% agree. I think we're contractually obligated whenever we have any cybersecurity conversation to at least mention or allude to AI. I think there are ways in which some of these tools can be leveraged to, as adversaries get more complex. Are there ways in which we can leverage some of these tools to provide a second layer of kind of verification or assessment? So I think there's a lot to be said about ancillary systems that can support the user, but also, as you mentioned, privilege, least amount of privilege, network segmentations, ways in which we can isolate people who don't need to be directly interfacing with critical systems, kind of keep them isolated and segmented in that sense too. So
Yeah. Yeah, for sure. That opens up the whole identity access management, realm of cybersecurity that is extraordinarily challenging in healthcare
yep,
environments. As you have, you could have residents, you can have contract people, you can have rights,
yep,
permissions, etc.
yep,
Temporary staffing on the nursing side, those types of things that often create, in and of itself, operational challenges, let alone access challenges that are kind of prevalent
100%.
in the space that we're in. Um, as you concluded that research, you said it was controversial. Is that because there's kind of this common norm, I'll say, frankly, not, across industries, not even healthcare, but everywhere, that training is really effective? I mean, is that kind of what made it controversial in your mind?
Yeah, and also you can imagine that the people who make their living on such trainings probably weren't super excited to see the research either. And so, again, I really want to emphasize that point that it's a single study. The methodology is not perfect. All we're doing is introducing some data to be looked at and a hypothesis corresponding with that data. And we are always happy and even encourage folks to say, "Hey, I have different data. I have data that shows something else." Unfortunately, sometimes the folks that kind of make the loudest noises don't kind of engage in that same spirit of like, okay, can we study your method? Can we look at what you do? And so that, I think that's where sometimes a little bit of the controversy comes from.
Yeah, absolutely. You mentioned a couple other areas that you guys have been researching and studying. I'd be interested to know what else are you working on right now?
Yeah, so I think to your point, understanding that clinical workflows are incredibly complex before you even think about bringing cybersecurity or information technology considerations into it. We're trying to break down, I think, some of the silos that exist between the clinical folks and the folks that are working on the IT or information security side of things. So when it comes to something like ransomware, I think a lot of resources and time and attention are spent on prevention, but I don't think we have a commensurate amount of focus on what do you do after a hospital is hit, right? And you're in this prolonged downtime period for those doctors or nurses that are suddenly having to revert to these, paper records or manual processes. And so we've been doing a lot of work to try to understand what are the key dependencies, what are the key technologies across specific clinical specialties so that we can design more helpful downtime procedures oriented to a cardiologist or oriented to a hematology oncology doctor. What are the critical patient populations that you really have to worry about versus the ones that'll be okay until you get your systems back up? So we've done a lot of work on from sort of a emergency management and business continuity standpoint, looking at those workflows. And we've also done some work that was virtually presented at DEF CON in the Biohacking Village a couple days ago on understanding from a historical standpoint, really going through the medical literature and identifying case studies and case reports of ransomware attacks in the different patient populations that have been affected to put together a platform that can help to model the patient populations most at risk, depending on what type of hospital you are, what services you provide, where you are geographically. So we're trying to bring a little bit of a public health lens, a little bit of an epidemiology lens, a little bit of a business continuity and emergency management lens to these incidents from a sort of downtime perspective that is relevant to doctors and nurses, because there's been plenty of focus and attention on the IT side of things, right? Incident response is fairly well established if you're working on just bringing back up the network or restoring your endpoints, but how do we help the people that are taking care of patients at the bedside?
Yeah, I love that. I look forward to seeing the results of those, and certainly happy to participate any way that we can in that effort, because I think you're absolutely correct. I mean, the biggest look, there's always progress to be made on the IT and cyber side and
Yeah,
bringing systems back online and the forensics, et cetera, which is an
right.
important component of it. But look, we're in the business of serving patients in these communities, right? And so when
Right.
that gets disrupted, I love to see energy put towards how do we not only build resiliency but survive these types of
Yep.
attacks that are only
Yep.
going to increase. Um,
Yeah, and I think that if you take a look at the sort of fundamental underlying business model, for lack of a better word, for ransomware. Like, ransoms are paid because these events are incredibly disruptive, right? Or because there's a lot of data at risk, or because that exfiltration of that data sets up regulatory penalty. Like, the impact of ransomware to a hospital, both operationally and financially, is huge. And if there are ways or methods in which we can mitigate that impact or reduce that impact to where it becomes something like an annoyance as opposed to a disaster, then you can start to address some of the underlying malincentives of the bad actors, and hopefully start to reduce this as a sector that is increasingly targeted.
That's right, because the adversaries want money, right?
Yeah.
Their whole point is to hold ransom and get money,
Yeah.
and or monetize the data, right? And so the less impactful that event is, the less likely that
Like, you are
they're
to
going
pay it.
to
Yeah.
gain monetary value out of that effort that they put towards that.
Yeah.
So I think that's exactly right. Making this more of like, because look, a lot of these health systems are organized for limited downtime. I loved when you were
Yeah.
talking about prolonged downtime. That's the real issue,
Yeah.
right? I
Correct.
can survive an hour or two. I do that
Yep.
with system upgrades, etc.
Yep.
Things oftentimes fail, but it's these long periods that really begin to impact, our care environments.
Right. And obviously, we are 100% focused on patient outcomes in the clinical care, but there's a secondary impact from just a business continuity standpoint, right? Some of these health systems are taking these 9-figure financial hits because many of the systems that they use to track and process claims and reimbursement, they are also impacted as well, right? So there's kind of this knock-on effect. They're paying a large ransom, they have reputational damage, then, oh my gosh, our billing just went down 50%. And if you're a rural critical access hospital with limited margins, like, that's an existential threat too. So ways in which we can reduce some of those secondary impacts are also going to make it more likely that we are able to survive these. We don't pay the ransoms, the bad actors don't get what they want, and then hopefully at some point this cycle can be interrupted.
Yeah, that's very, very well said, and it's a great pivot to my next question, which is around budgets in health systems, both large and small, are small, right? We operate
Yep.
on grocery store margins.
Yep.
There's various studies out there. A large percentage of organizations are operating in the red. So every dollar that we allocate towards cyber is a dollar away from the bedside. There's always that dynamic. What recommendations or thoughts do you have around thinking through, applying the appropriate amount of capital in cybersecurity while also balancing the needs to deliver care? How do you think about that, or have you given that much thought?
I mean, we've given it a lot of thought, but it is such a challenging question, right? And I think, to kind of circle back to the phishing study, like, this is why evidence is important, right? Is because you have a limited amount of resources and you need to deploy those in the most impactful way. And even just comparing cybersecurity to the clinical question, like you said, right? Like, how do you, as a health system CISO or a C-suite, what is the risk benefit approach of spending $1 million on a cybersecurity tool versus just hiring more nurses because your clinic is understaffed, right? That is an incredibly challenging proposition. So I think, ultimately, workforce is a huge problem, right? There was the Health Sector Coordinating Council put out a white paper a couple of months ago about sort of resource constrained hospitals, and I think, like, only 15% of them said that they had as many staff members as they needed to fully staff their cybersecurity team, right? So I think workforce, above any type of tool, above any type of framework, consultants, things like that, just kind of staffing these hospitals with folks that can be their hands on keyboard, is incredibly important. And that in of itself is a big challenge, right? It's going to be pretty hard to convince somebody to go work at a rural hospital in the middle of the country when they could make twice or three times as much money working in industry, finance, some of these other sectors too. So I think one of the major problems that we need to address as a community, as a sector, is staffing up a cybersecurity talent pipeline that is exclusive for healthcare. So then I think the next question is, what are resources? Are there ways in which you can squeeze blood from a stone? And that's where I hope that our open source clinical resiliency and continuity playbooks are helpful. The downtime, work that we've done can be used. We're going to make it public and open source here in a couple of months at the end of this project. It's not going to be perfect. It's not going to be specific to every institution, but can we put out resources, open source tools, things like that, that can be integrated and adopted by these health systems that don't cost an arm and a leg? And then at some point, you probably just have to kind of say, there is a role for larger funding, right? Particularly for these small rural critical access hospitals, if we're going to start introducing concepts, things like minimum cybersecurity standards, accreditation characteristics that take into account cybersecurity, there very well may need to be a support for that type of work and effort and resources at a higher policy level. So we don't get too much in the weeds of the partisan advocacy here at the center, but I think that especially thinking about those rural or resource constrained hospitals, there may well be a need for some additional support.
Yeah, I think that's right. I mean, look, we talk to health systems all the time, and a lot of them know what they need to be doing, but they either can't find the people, to one of your points, or they don't have the capital to do it, right? And so
And
even
I
if
just
there
say
was,
too, and that is a personal pet peeve of mine in certain situations. And I'm sorry to interrupt, but a lot of people act like these rural hospitals don't know what to do. Like they've never heard of cybersecurity before, and they're just out in the weeds, and that they need to be helped. You're absolutely right. The people that are there, they know exactly what they need to do. They just don't have the people to do it for them.
that's
Yeah.
right. They don't have the people, they
Yeah.
don't have the funding, they can't attract the talent,
Yeah.
away from the coasts or away from other industries. It is a significant challenge.
Yeah.
When you're paying significantly less than, even if you're in, there's another business in town that'll pay you more money, right? I
Yeah.
mean, so it is a big challenge. I agree, and I always tell people that everybody that I've met in healthcare cybersecurity believes in the mission of the
Yeah.
hospital, knows what they're doing,
Yeah.
or is open to learning more about what's happening. And we got a lot of really good people. We just need more of them and more funding, and that's a
Yep.
challenging topic, for sure. But one last question that I had for you is, I have a lot of people that I talk to that struggle with talking cybersecurity with physicians and the importance of it. And in some organizations, the cyber team or the IT team is viewed as the team of no, or the barrier for this tool, or the barrier for this process they want to enhance, or disrupting care. What advice do you have as to how cyber professionals can frame cybersecurity in a contextual way that clinicians would understand the value and ultimately the potential protection or impact to the patients that we know these clinicians are fighting for?
Yeah, it's a great question, and it's one that I would like to think we've had a little bit of success in addressing, and that comes from trying to break down some of these silos and encouraging dialogue between these two teams, right? And I think, as you alluded to, everybody believes in the mission, right? The mission is to deliver safe patient care, and it takes a little bit of a challenge and a little bit of a stepping outside of a comfort zone for somebody like a CISO or a CIO, I think, to really dive deep into the clinical workflow, the realm. Go hang out in the doctor's lounge and get a sense of where these dependencies lie, how different platforms or tools are used to take care of patients. But once you show a willingness to engage in that type of discussion or fact finding, then I think the clinicians realize, okay, this is actually something that is an important institutional objective. It helps us to ensure that we are delivering safe patient care. 5 or 10 years ago, I would have to teach people about ransomware or teach people about medical device vulnerabilities, and folks are seeing this in the news often enough to realize this is a big problem. So I think there's already a little bit of buy-in there, and so I think it's just important to kind of frame this as like an important thing to do beyond just checking boxes for compliance, beyond just, hey, you guys have a mandatory annual cybersecurity training that you have to do alongside all of your other trainings that take 20 hours a year out of your time. Moving away a little bit of that, from that prescriptiveness, into a shared collaboration between two teams that work together to take care of patients, that has been successful in our approach.
Yeah. Get out from behind your desk or office,
Yeah.
and go around and see what's happening, and really
Just
understand
learn.
the
Yep. Talk to
relationship.
people. Yep. go to your cardiology colleague, say, hey, when you're taking care of a heart attack, like what systems do you need? What systems do you not need? How do we think about that in terms of our larger, network strategy or risk frameworks? Like what really is like the stuff you gotta have versus the stuff that are the bells and whistles? And just being part of that conversation, I think, will engender a shared responsibility and commitment.
Yeah. Yeah. What do you think about AI? Everybody's talking about it. I'm sure that there are a lot of your colleagues and probably you as well that are intrigued
Yeah,
with the large language models and the impacts that
yeah.
they can have, both positive and potentially negative. How are you thinking about AI, both from a clinical perspective, but also from a cyber perspective?
Yeah, so in my non-cyber research, I do a little bit of work in the perioperative informatics space and look at ways in which we can leverage some of these tools. Primarily, I think to help address workflow challenges in healthcare. To be quite honest, so one of the things that we do is we have sort of a pre-surgical or pre-anesthesia clinic where patients will come in before they have surgery, and we'll evaluate them and their medical history and the medications they take, and understand how we can best optimize them for surgery, which is associated with decreased costs and better outcomes and all these things that we know in the literature. We just don't have enough nurses or anesthesiologists to be able to have a system like this at every hospital across the country, right? And so are there ways that we could use LLMs to sort of help triage patients, put together a summary that then a nurse or an anesthesiologist can more effectively review? Maybe that helps with some of these workforce challenges. The problem with everything else, like we've been talking about today, like everything else we've been talking about today, is that there's just not a huge amount of evidence yet to show that these types of tools are actually making the clinical impacts, saving the costs, having the outcome differences that we seek, right? People are publishing lots of proof of concept papers. People are publishing lots of validated models on data sets, but taking it that last mile and really integrating it in a way that makes sense clinically is like work that is still ongoing. And so I want to reserve a lot of my assessment until we kind of see how are we implementing these technologies, do the benefits outweigh the costs, et cetera, et cetera. From the cybersecurity standpoint, I do think that these are incredible tools for adversaries. So people's jobs are not going to get any easier. But we may also have the ability to leverage, education, ways in which we can sort of apply at scale framework. So I just got back. I'm not sure if you went to DEF CON or not, but I just got back from DEF CON last week, and they had the AI Cyber Challenge. I'm not sure if you were familiar with that, but that was a DARPA and ARPA-H exercise competition between teams that were kind of building these automated cyber reasoning systems that were like assessing for vulnerabilities and finding them and patching them in real time. Like, I do think that there is a lot of promise and potential with those types of techniques, especially if they can be leveraged in a cost effective way at some of these smaller hospitals that may not have the on the ground talent. So exciting times, but there's so much in the way of validation and data and evidence that I think right now is currently being drowned out by a lot of hype and pitch deck.
Yeah. Yeah. Do you think we're 3 years, 5 years away from realizing some of those benefits? I mean, you read one thing that it's going to be here tomorrow. Some people say it's here today. Thoughts on, when we're going to start realizing or being able to at least analyze whether or not these benefits are true or not?
I will just say I'm not a formally trained computer scientist. I am a humble country trauma anesthesiologist. I don't have that great a crystal ball.
Yeah.
I will say we are certainly in our health system deploying a lot of really interesting tools. We're collecting a lot of data, but I can't really comment on when exactly we're going to really feel the impact of these technologies.
Yeah. Yeah. I think it's important to stay grounded in the fact that the systems that we're running in our environments are either impacting or directly connected to patient care. So making sure that we get it right, I think, is going to be really important at the industry level, right? And not rush to claim victory one way or the other.
Yeah, and I mean, just from my fellow colleagues that are starting to play around with some of these tools, like we've all had the experience where we pull up ChatGPT or Claude or Gemini and like do something incredible, right? Like you're just like, holy cow, I cannot believe that this model did this. That's amazing. Like we're doomed. And then the next time you give it a prompt, it like can't spell blueberry correctly, right? And so when it comes to integrating these types of like clinical decision support or bedside doc assistance, like we really have to make sure that the margins of safety are there, because that type of same tolerance for error is not acceptable in a clinical scenario. Being completely wrong and off the base 10% of the time, 1% of the time, like we don't accept that right now clinically for human beings. And so I think we have to be very, very careful with integrating these tools directly into patient care.
Absolutely. I completely agree with you. I think that it certainly has good promise, but time will tell, and lots of iteration between now and the time we fully feel the impacts of that,
Yep.
at scale. So, well, listen, I've really enjoyed the conversation today. Anything else that you want to share that you're studying or interested in right now as it relates to the intersection of healthcare and medicine and cybersecurity?
We've got a lot of stuff going on. I should say that here at our center, not just me and my research partner, Christian Demeff, who's an emergency medicine doc. We've got incredible computer science colleagues. We've got public health folks. We've got economists, a bunch of incredible students, which gives me a lot of hope for that workforce problem of the future. So there's a lot of multidisciplinary collaborations, other projects. Maybe I can share our website link with you to be included in the show notes so that folks can go and check out some of our other papers and projects. And then we are hosting an academic symposium here at UC San Diego, October 27th and 28th, that we've done for a couple of years now, trying to really create a research-oriented community in this space. There's no registration cost, free to attend, so I can include the link to that as well. And love to meet people, love to come up with new collaborations or project ideas.
No, that's fantastic. I was going to ask how people could get a hold of you, but we will absolutely include that information in the show notes, and really appreciate your time today. Thank you so much for joining. I'm Dan Dotson, and this is Cyber Survivor.
Thanks, Dan. Thanks, everybody.